Thank you very much. First of all, I want really to thank our Turkish colleagues for coming to express my solidarity with the loss and to say that we should hope and each of us do what he or she can in order that here and there peace will overcome violence. To be the second one has some advantages. I can react to what David said. It has some disadvantages because he sets the limits of the discussion. But and also because he already addressed, I would say that we agree in some of the first statements, especially concerning the significant, strong and good points our national health insurance law has. And I also want to agree with him that making or including long-term care, mental health, and dental care into the healthcare system, into the public healthcare system, is one of the main things we can do for a more equal and efficient healthcare system. I still have to disagree with him concerning the significance of the blurring of the limits between private and public and its possible consequences to the healthcare system as in the future. I was thinking not about, you spoke about three modes of privatization of financing, which I completely agree. I wanted to speak about three modes of privatization of healthcare as a whole. One of them is privatization of financing, and since '95 we have seen an increase of privatization of financing in the three ways David mentioned, even though it is true that in the last years the share of out-of-pocket has decreased. The second point is privatization of ownership, in which or to which degree ownership of services, ownership of provision is public or private. And there we also, I wanted to focus on the blurring boundaries between public and private, so I didn't bring figures, but since the early 80s, we can see that many of the development in the healthcare system in terms of beds, in terms of institutions, in terms of laboratories has been done by private owners. And the third point is, the third way is the blurring boundaries between public and private. I want to bring two quotes from the State Comptroller's last report. The first is, along every public hospital there is a health trust whose budget represents 40% of the hospital's budget, and the health trust is a kind of semi-private institution or semi-private organization existing within a public hospital. The second one, in 2012, remarked the Comptroller's Office that the Minister of Health does not effectively supervise the functioning of the Sharab. The Sharab is this system that David told that exists in the Jerusalem hospitals, by which physicians working in a public hospital can do private work within the same hospital, part of the money going to the hospital, part of the money, or the big part of the money going to the physicians. So in 2012, remarked the Comptroller's Office that the MOH does not effectively supervise the functioning of the Sharab, and that it is possible to suspect that relatively simple surgical procedures are performed within the Sharab by highly specialized physicians in detriment of the public system. As to July 2014, the Ministry of Health did not publish appropriate regulations. Now, you could say, okay, there is an agreement between David and myself concerning regulation. It's what the Comptroller says, we have no regulation. But in what we differ is that, let's say, the same skepticism David heard about the possibility of separating public and private, I have concerning the regulation, the possibility of good regulation. I would say that in a way, waiting for the regulator is like waiting for Godot. The regulator will not come eventually. I want to say something else, that the public and the private systems work with opposed logic. In the public system, money is the means to provide health services. In the private system, services are the means to make money. So those are two logic which are in a way opposed, contradictory. But the result is that when you mix the two logics, the logic that is dominant is the logic of the private service. In a way, because people are not kings, many of them are knaves, you know, quoting a researcher of the British system. And physicians, even though they want to think, or we want to think about ourselves like being morally superior, are, in the best of cases, morally similar to the average population. And when we have incentives to prefer the person who pays to the person who has a need, we prefer the person who pays, or we tend to prefer. I don't want to make generalizations, but it happens much more than it should happen. Now, in the world, and that is interesting, because when we are speaking, there is a kind of conceptual confusion, because when we speak in Israel about public-private mix, it's not the public-private mix as we usually know it from other countries. There are mainly four dominant ways of private-public mix, at least in relatively rich countries, and Israel is a relatively rich country. We saw the GDP figures. One is what is called private finance initiatives, on two forms: build, own, operate, transfer, or design, build, finance, operate. The example is the UK. The other way, the example is Portugal, is as the previous model, but some of the healthcare services also operated by a private provider. The third system is a private firm operates a specific service, usually a hospital, and sells services to the public system. This occurs, for example, in Germany and Finland. And the fourth model is what it's called the Alcira model in Spain, which is in a way a private sick fund. It's an organization which receives money by capitation in order to take care of all the healthcare necessities of the population in a determinate region. But what characterizes these four types of public-private mix is that in the four of them there are still clear boundaries between what is private and what is public. And what happens in Israel is that those boundaries are completely blurred. What are the models we have in Israel? The first one is what are the models of what is called the public-private mix that we have in Israel. The first one is, as David told, it's the sharab. The second one is the private insurance sold by public sick funds. David called it supplementary insurance. I would say that according to OECD standards, I think that in many cases it's supplementary insurance, but it's also a duplicate insurance. Because choice of doctors or second opinion, it's true, it doesn't exist within the public system, but it's a choice of doctors or second opinions for services that are provided and are included in the healthcare basket. So in a way, it's more a kind of duplicate insurance than of real supplementary one. Then private hospitals owned by public sick funds. The biggest private hospital chain in Israel, Asuta, is owned by the Maccabi Sick Fund, which is a public non-for-profit fund. We have this kind of strange construct in Israel where non-for-profit organizations own for-profit firms, which is queer by itself and creates a lot of conflict of interests. Then we have private services sold by public hospitals. Public hospitals, for example, outside of Jerusalem, by the public hospitals can't do what is called sharab. But for example, yes, I remind the sharab is the possibility of public physicians in public hospitals to do private work within the public hospital. Okay, this is what happens in Adut and Shaarei Tzedek that David referred to in his talk. Now, in hospitals like the Ichilov Hospital or the Tel HaShomer Hospital, they do not do sharab, but for example, they sell services not included, privately sell services which are not included in the healthcare basket. For example, lab tests that are not included in the healthcare basket, like homocysteine test, or another one which is called free PSA, it's a screening test for prostate cancer. They can sell periodic checkups to the private insurance companies. They even have a kind of mini private hospital for cosmetic surgery within the limits of the public hospital. So we have those kind of hybrid, a kind of centaurus, half a human, half a horse, that are really queer. It's not the private-public mix we know from other countries. And one of the problems is conflict of interests, because when the person who has to decide, the healthcare provider who has to take decisions within the public system, you are not really sure why he's deciding what he or she decide, because what really matters? The interests of the public system or the interests of the private firm owned by this public provider? And the state controller has pointed out this point in his last report. Then we have medical tourism, which is also a kind of private service sold by the public hospitals. And once again, we are speaking about, I could understand that if we had in Israel a huge non-used capacity, then you could claim for efficiency reasons that it's logical, it's rational to, for example, engage in medical tourism. But the fact is that we have overused and we don't have enough public capacity. So when we are charging a fee for the medical tourists, we are not putting our accent on the marginal cost of this service, because we are using otherwise unused capacity, but we are using a capacity that goes at the cost of the Israeli citizen who has no alternative than using the public system. So we have a whole construction that in a way it's bad both from a point of view of efficiency and of the point of view of equality. These are a private health insurance coverage by type, and you see Israel is only second to France and the Netherlands. And in France and the Netherlands, because of the system, you need supplementary insurance. In Israel is really, and I think the answer to the question, to Rami's question, is very complex one. We are for sure risk averters. There are cultural reasons that make Israelis much more sensible to the kind of publicity that says that if you do not buy the private insurance, then you are you know, you are in a way damaging or you are betting on the health of you and your family. We are really culturally risk averters. We are also, in a way, at least the Jewish Israelis, a people of hypochondries. So we need to be sure, we need that second opinion. But there are also other kind of reasons, and we have to take them into account. One, there is a kind of relationship between the ways in which the system didn't develop at the same rhythm that new technologies and new possibilities and the fact that people buy more insurance. And then, and for me that is the main reason, because this blurring of the boundaries give incentives to the sick funds and to the physicians to support this supplementary insurance. There is a process by which physicians and managers at the public sick funds are pushing the public to buy insurance. They are convincing the public that they need that insurance. Now people, and here we have a gap in information, a gap in knowledge. If my physician, if the director of the clinic where I attend says to me, well, it is really good for you to have a supplementary insurance, it influences the way I behave. So if I create a system where the sick funds and the physicians have an incentive to increase the percentage of people holding supplementary insurance, then that's one of the results. And here is, I'm sorry that it's in Hebrew, this is the change, the increase in supplementary insurance sold by the sick funds from 1999 to 2008. This is the increase, the blue line is the increase in private insurance. The second line is the increase in supplementary insurance, and and this is the increase in general private insurance, not in health insurance. So we can see two things here. One is that the increase is both in private and supplementary insurance, and second, that for the private insurance companies, health insurance is a big business and a big issue. Now, the result: growing inequalities and growing inefficiencies. Inequalities in access to healthcare services between the better off and the poorer. Inequalities between center and periphery. And one point about what David show you the differences, and it's true that those differences should be looked upon with a microscope and not in the big and not only in big terms. But it is also true that when we speak about, for example, 80% or 73% with insurance and 27% without insurance, and that insurance is relatively not expensive, we are not speaking about the need of make co-payments when you use the insurance. Because one thing is that you have 20 shekel or 30 shekel a month in order to buy for yourself supplementary insurance, and the other thing is that you have 1,500 shekel that you need as co-payment when you go for surgery and you use the supplementary insurance. So what we see is that there are differences in the percentage of use of the supplementary insurance, and this is especially so between the center and the periphery, because most of the facilities that provide services paid by the supplementary insurance are in the center. And it is true that we are not so a big country that you can take a car and travel from the periphery but to the center, but still we see that there are differences, significant differences in the use of those supplementary insurance between center and the periphery. Inequalities between physicians, because those physicians who increase the revenues are mostly surgeons and the top surgeons. Primary physicians, family physicians become a kind of proletariat of the within the profession. It would be, I'm exaggerating, they are very well remunerated, so they are a well-paid proletariat, but it creates very, very big differences between physicians. And then we have inefficiencies. Inefficiencies due to duplicate insurance. The fact that 34% of the population has both supplementary insurance and private insurance is money wasted. Inefficiencies due to duplicate use of services, because people go to sometimes to a doctor in the public service, and then they use their private insurance or the supplementary insurance to go to the same doctor or to a similar doctor in the using the private. And inefficiencies in the use of technology. As David said, and I completely agree, we have a very, very accountable and, in my way, intelligent and fair system of increasing or adopting new technologies and new drugs. By this supplementary insurance, we have a way to bypass this good system, and I'm not sure that this is a kind of free research for introducing new drugs. It's in a way introducing those drugs or those procedures that are popular in a certain point of time, and that doesn't mean that those are the most efficient or the more healthy procedures. Is there an alternative? I think there is an alternative, and I think the alternative is, even though I agree that a complete separation between private and public is impossible, but there is a possibility to rebuild the separation, redrawing the borders between public and private, including the duplicate insurance within the public one, giving some possibility of choice, I would say a regulated and controlled choice within the public system, giving the possibility of a limited possibility of a second opinion within the public system that would allow us to increase taxes, the health tax, but not making people pay more, because they would pay more health tax, but they would pay less in terms of supplementary or private insurance. We can make a clear separation between public institutions and private ones. This legal construction by which a non-for-profit organization can be the owner of a for-profit organization is, in my opinion, an absurd, and there is no logical reason why we couldn't stop it. And finally, we could try, there is the Canadian example, for example, to make healthcare providers choice between working within the public system and working within the private one, and not allowing for benefiting from the advantages of both of them. And one last word about austerity. Our society, at least, is richer than it was 20 or 30 years ago. So austerity, it's not a natural thing. It's a kind of political choice. We heard in the morning that in Israel, direct taxes have decreased in a very, very significant way. So austerity is not a kind of natural disaster. It's not a tsunami. It's a political choice based on interests, on class interests, on elite interests. So the fact that we have to prepare ourselves for long-term austerity could be replaced by thinking about how can we define a kind of economic way which does not take austerity as a kind of natural disaster that we are condemned to suffer. Thank you.